Welcome to this provider education session on post-op conditions versus complications. Many findings after surgery are expected and managed routinely, but some cross the line into a true complication, and your documentation needs to say so. Today we'll cover the 48-hour rule and 8 common post-op conditions, with what's expected and what signals a possible complication. So when does an expected post-op condition become a complication? In general, when any of these 4 things happen, it persists beyond 48 hours postoperatively. It results in an extended hospital stay. It requires non-standard treatments or interventions, or it occurs as an intraoperative complication. If any of these apply, your documentation should reflect a complication. Let's start with the blood. Anemia and acute blood loss anemia result from blood loss and hemodilution and are managed routinely with intraoperative and postoperative transfusions. Think possible complication when ongoing transfusions are required, or there's evidence of postoperative hemorrhage. Coagulopathy and thrombocytopenia can develop from platelet and fibrinogen consumption and hemodilution, with FFP and platelets typically administered during surgery. It may be a complication when there's significant bleeding requiring transfusion of blood products, and continued FFP and platelets postoperatively. Next, circulation. Cardiac arrhythmias often occur due to conduction disturbances or transient ventricular ectopy after reperfusion in cardiopulmonary procedures. They become a possible complication when episodes are prolonged, cause injury like myocardial ischemia or infarction, or require further intervention such as cardioversion. Hypotension may occur within 48 hours after surgery due to fluid shifts, and vasopressors are almost always administered during this period. Think complication when it's prolonged, or progresses to shock. Now, chemistry and fluid. Metabolic acidosis can arise from high saline volume and is managed post-op with bicarbonate infusion. It's a possible complication when persistent beyond 48 hours, with a pH below 7.35, bicarbonate below 22, or lactate above 2.0, requiring ongoing bicarbonate infusion. Pulmonary edema develops from inflammation and fluid imbalance. Think complication when there's sustained acute pulmonary edema, not attributable to chronic heart failure. Finally, the chest. Pleural effusions come from inflammatory fluid shifts. They become a possible complication with persistent drainage beyond 48 to 72 hours, increasing effusion volume, heightened diuresis, or the need for thoracentesis after chest tube removal. Pneumothorax is associated with chest tubes used during surgery and generally resolves after the tubes are removed. Short-term residual pneumothorax is common. Think complication when it requires extended management, specifically chest tube placement beyond 48 to 72 hours. A few other conditions are worth keeping an eye on post-op. Acute pulmonary edema. Acute or acute on chronic heart failure, with the type specified. Acute pulmonary insufficiency following surgery, with the type of surgery. Acute tubular necrosis. And shock, cardiogenic, hypovolemic, or hemorrhagic. Each of these has its own dedicated topic in this series, so check those out for the full documentation guidance. The key takeaway: a post-op condition is expected until it persists, escalates, or extends the stay. Beyond 48 hours, an extended hospital stay, non-standard treatments or interventions, or an intraoperative event, that's a complication. Call it what it is and document the evidence. Thank you.